objectives that we're looking for in this section is we're looking at incorporating the values of TCP into our plan. So we're also going to look at identifying the design of the items as well. So the treatment plan used to be this document that, as much as we would say it was a living document, we'd write it out, pop it in the chart, never look at it again for a year. How many people, you can raise your hand or not, did that? I did.
That's not true.
I will admit it. So what we're emphasizing with these new plans is utilizing it throughout treatment because we're doing short-term goals. These are goals that we're actively working on. One thing that I emphasize with this whole entire process is that we want to have it on us to say, are we in line with the treatment that we were looking at originally? So if you're going out to a client and the goal was surrounding skill acquisition to get to employment, but you're constantly working on housing or stopping going into the hospital, we may not be in alignment anymore. And so we're pulling that thread from the assessment into the narrative and now into the treatment plan to find out what are the things that we're going to continually be working on in treatment and updating as we go, so that it's not just this document that's sitting there somewhere. And this is something that the client will also feel proud of. Some even say that the way we write it, they may want to put it up on their fridge or in their room. So it's something that reminding them of, this is what I need to do every day to take care of myself, similar to a RAP plan in a sense. So as we know, a plan to get from A to E takes a lot of steps in between. So if the way that I kind of like to do this diagram is think of a lake. You're on one side of the lake alongside of the client. Remember, driver's seat and co-pilot. On the other side of the lake, there's a big pot of gold. That gold is that goal, those desired results, the things that the client really wants. How are they going to get there? They're stepping stones across the bridge or across the water. That's what these things are. We need to do the different steps to get to the larger goal. And those are the short-term aspects and the interventions that we're doing to help them get there. Remembering that this whole process is a collaborative partnership that we're doing in partnership with the client and their family if that's in their lifestyle. We may have those who are working in the group in the adult side with our example of Padma. We may not be incorporating the family right then, but maybe in the future we are. With those that we're using the example of Diana and her family, that's strongly integrating the family structure into things. So those are things to think about when we're partnering with people, is actually sitting down, doing the plan with all that are involved. And like Steve had tapped on earlier, someone's family might be their board and care operator, so integrating them into the planning process is very important in kind of bridging that gap that may have occurred before. Now they're more than just the person collecting the bill and feeding the person, but they're also helping out with the treatment so that everything's integrated together. So what comes first? We don't want to step too far ahead. Often we're jumping to, this is what our goal for the person is. We now have to step back and say, what stage of readiness is this person in, or is this family in, that they're going to be moving forward? So we're only going to go as far as the client wants to go right now with a little bit of assistance. So that's where we're starting from. Instead of at the end result of, okay, we're done with treatment in 6 months, it's let's evaluate along the way. We want to be consistent with the perspective of people that are served and build upon their expertise. This is where the strengths come in, the cultural norms and values, really embracing those within the treatment planning process, but also in the actual plan itself. So on the other side, we've been getting some questions about situations, particularly with the F&C side, where trauma might be exposed historically, or you may get two different stories from the family or from the client. Do you write it all in the narrative? Do you put it all in the treatment plan? Because you're going to be reading this back to the person. You may be giving them a copy. We want to be aware of those things. And if it's going to cause more harm, we want to look at the risk and protective factors. We want to look at any legal obligations and mandates. So if they're involved with probation, how is this going to impact things? If there are courts that are overseeing things. We don't want to leave out important things to the client, but we also want to kind of integrate that aspect of being careful what we're doing at the same time. Does anyone have any questions so far on that or other aspects? Did you want to add anything to that one?
No, I think it's good. Just from my perspective, the interesting piece, I'm an FNC provider, but neither Padma on the adult side or Diana as that 9-year-old girl reflects my clients at all at juvenile hall. So for all of you, as we're moving into more discussion about the treatment planning process, I would encourage you all to start thinking about who are your clients that your staff are going to be writing narrative summaries and treatment plans on. And hopefully we'll be able to surface some of the questions that you might have. How do I take these exercises that we're doing today and then apply them when I get back to my clinic on Monday with clients that may look and sound a little bit differently than the 2 examples that we're working with right now.
Thank you. So remembering that exploration is key and really finding what's the meaning for the individual will help kind of clarify where to go with the narrative and with the plan. So finding the right balance, quite often, so many times before it was, okay, the client doesn't know what to do, so I'm just going to go to this extreme side of what I think is right for the person. It just makes it easier. All the way to the other side of, and I used to do this too, where I'd be like, here you go, write your own plan, you know, because it's supposed to be their words. Where do we find the balance in between both areas? It's finding that mutual agreement of, okay, this is what you want to do. Here are the steps that you and I have together outlined that it's going to get you there. And that's that recovery zone right here that we were talking about. This is the area of balance where we're like, okay, this is the step. So if you've got a kid that you're working with that's saying, I want to go to Disneyland, we may think it's way over there, but how can we get it to there when we're saying, well, no, you need to stay in school all the time? There's a middle area to that we can build from. Same with the adult system. If there's something that's way out there like, I want to be an astronaut, I'm not going to dismiss that, but I'm going to say there's a lot of things that take to get there. So we need to find how to bridge those 2 areas of what I think and what you think and bring it together. So as we said, these are the elements of the treatment plan that you guys are going to be working on. And we're going to go into each one of these in greater detail. So if you have questions, please ask them. So desired results. Not too much different than what we've been doing. This is a quote from the individual. If there are family members, you can put their quote in there as well. But it has to be a direct quote. And I encourage you guys to really work on the skill acquisition area on this, because I often see people take the very first thing that comes out of someone's mouth without really exploring what that is. That's where that narrative summary can come in, because you've already, like we had said earlier, started exploring the desired results in the narrative, and that's going to feed right into the plan. So we want to find out, what is their vision? What are their hopes and dreams in life? This is the larger picture. So what are their hopes and dreams? The desired results are something that are going to continue throughout. So you may be keeping those desired results for a longer term, because that's that pot of gold that we're trying to get to across the lake. It's also an engagement tool, because this is the part where someone starts really exploring, well, wait, you want me to talk about the things that I like, that I want, rather than the things that are in the way? Well, yeah, that's the whole purpose. I want you to get there. And that's going to lead into the next area. And one piece that I like to pick on in this area is that existence of ambivalence. Oftentimes we get, and we talked about this earlier, the folks that say, I don't know, you're the expert, you know, whatever, I don't know what I want. It's really kind of exploring where that ambivalence is coming from and what things really matter in their life. And when we did the narrative, we picked up on those strengths, and we can feed people that information to say, well, you've talked about these things before. How does that stand with you now? So that's the piece that I really like to take from the desired results, is kind of exploring what are the pieces that are really important and valid in your life right now. Yeah, the desired results are their goals, their wishes, their dreams. So if you're saying, I would, you know, if they've elaborated to say something a little bit more, then I would put that statement in there if it's like one sentence or something, or 2 sentences. But putting your spin on it or your interpretation, that goes in a progress note, or that goes in the narrative, because that section that belongs to the client.
That's what I understood, but you said explore
Because I'm saying don't just write the first thing that comes out of their mouth. You know, don't just write I want to be happy. You know, find out what is it and then write I want to be happy with, you know, in my school setting, or you know, whatever it is that yeah, be more getting more specific. You may not get more specific than that. The person may just state, nope, that's what I want, and that's perfectly okay.
And to add on to that, Lorena, because I've certainly been in those situations where I'm working with a client to expand on something. I get you want to go to Disneyland. Why can't you go to Disneyland? Well, my mom says I need to behave in school and at home and whatever else. And some of what I've done is, as they expand on that, I may say to them, well, so then is one of the things that I'm hearing you say that you're interested in this, and now I'm the one that's describing a little more detail, and they say yes, then I'm gonna say, so would it be accurate if we put down here that you're saying you want to do this? Then I'll put that in quotation marks. And I feel at that point, there's a bit of a fine line there, but as much as possible, we don't want to be quoting a client on something where they're just like, yeah, fine, put in whatever you put in there. So I think there's a bit of a delicate balance there, but we don't have to just put the first thing that comes out of their mouth.
For that one, it was more extrapolating, but you could put those three in there, or you could say, well, which one, and I think she did this in the video if I'm not mistaken, which was, which one of those three is the most important thing to work on right now? And you could do that as well, and have the one from the parent and the one for the child in there. So you could do that. Generally, that's the approach, but if they're like, no, these two things are really what I want, you know, you just have to remember to explain, while we're working on those things, we're going to take these steps, and it's going to take a little longer possibly, because you don't want to overwhelm the plan. So desired transition is a new area as far as the title, but it's something that we should have been doing all along. Another way to think of desired transition is, this is the discharge planning piece. So it's putting discharge planning up front and center from the get-go. So we're looking at that picture of the person of, what is it going to look like when treatment is over? How will I know that we can either move to the next step, or that you're ready to move to another clinic or be done with treatment altogether? Give me that description. It could be a couple of things, it could be one thing, whatever it is, you really kind of want to get that picture from the individual. So that's what desired transition is, and that's that piece that really starts describing how, you know, getting a clear idea. So it could be that the person is consistently going out and participating in events outside the home without any support from us, because they've got natural supports in the community. So that's an example of desired transition. Any questions on this one? Because this is a newer element. It's that collaboration effort. And you're basically asking the person, how will I know that you're ready to move on? You know, when will you not need us? The meds only, you mean? Or we'll tap on that stuff. That's the area that I tend to tell people, if all they need are meds, then we need to be moving them on to either an FQHC, private psychiatrist, PCP. For those that are in FQHCs, that kind of formulates things a little bit differently, because for the traditional clinics and the FSPs, if we've got someone that's med only, that doesn't match the service need that we're providing. You know?
Yeah, so, and that's something that very much as a system, we're moving towards a model that would allow us to do that. What we have right now is that our FQHC programs aren't yet doing TCP, so they're not having to struggle with how do we do this for those folks. But certainly there's a move with youths, for example, who are only taking ADHD medication, where in a lot of cases our current clinics have those folks, and we're trying to write meds only treatment plans. We want to move as a system to a point where we can get that person back to their primary care doctor, and the PCP then has the comfort level that while there may be other mental health components, they can prescribe the ADHD meds, and we don't have to have them in our specialty mental health programs.
Similarly, on the adult side, I tend to challenge anyone who says if they're case management meds only, I say, then why are they at our clinic? And they're like, well, they don't want to leave. Okay, what is it that they're depending on you on besides, oh, well, they're just comfortable with their doctor. Okay, sorry, it's time to move on. Or it's, they're going to lose their housing if they don't have my continued support because I see them twice a month or 3 times a month. So then it's more than case management meds only. So it's exploring what truly is going on here. Are they truly meds only, or are there other components that are contributing to them needing to stay in there? But that's a great question. Thank you. This is actually the part that I think a lot of people, truth be told, have been struggling with because it's so new, because they don't know how to approach it. One area that you can use for this and even the desired results is the miracle question. If you woke up tomorrow, or if you didn't need me anymore, what would that look like? Give me a picture of that. Even if it's just a couple things that they're able to do, that's something that you could really utilize.
Yeah, and I would add to that if you go back to the picture that Amanda used of a lake with stepping stones and a pot of gold on the other end, one of the things we might want to be talking with our clients about is that my job is to get you halfway or 3/4 of the way across those stepping stones. And at the point where you can see, okay, I've got to step here, here, and there, and then I'm going to be at my pot of gold, my desired results, what's it going to take then to get us there?
Actually, that's pretty easy. I'm off probation. I'm not on the court anymore.
And that's exactly the point, because the clients, sometimes that is the client's desired results. Then when you say, well, what is it going to take for your PO to be able to, let you off probation? Then they'll say, well, I need to, quit smoking weed. I need to do this. I need to complete a program. You might put that all up in the desired results. But then, any sort of symptom management around, recovery and their substance use and anything else, that may be a broader goal that we're not necessarily going to get all the way there with them. But we may say in the desired results, when the probation off, we're going to work with that piece. And
You have to.
Yeah.
when the PO is off, lets me off probation, we're going to know that you're successfully managing your challenges at the level that, we're
You don't
willing to
reoffend,
move you on.
get back in the system.
And we're
Yeah.
gonna move
A
you
hug
into
from Judge
peer
Manley.
support.
You get that cake at the end.
The minute I get that hug from Judge Manley,
And the cake.
I'm gonna know I need to be.
Well, and the cultural shift is big here because not only are we changing the culture of us as the treatment providers, but for those folks that have been in the system for a while, the people who come in and out, this is probably the biggest piece of your treatment plan that's going to be a shift for them even because A, we haven't been talking about it. B, I've been with you for 20 years. Or I've been with you even for 2 years and that might feel like it. Those are things that now we're actually tapping into that. We're actually breaking the habit of the rehearsed desired results. That's what this piece is going to do. And like we said, we don't expect you to walk out the door and be like, now I totally, I'm going to write these fantastic, brilliant pieces. There's going to be that practice in learning how to ask those questions, how to interact with these things and develop them. So, and that's what the supervision piece is. Not only are you guys going to be supervising others, but getting your own coaching through the coaching calls are going to help that.
You want to say something about that?
About which?
The coaching calls.
The coaching calls?
They don't know about the coaching calls.
Oh, I thought you mentioned the coaching calls earlier.
Let me
So-
pause
People know
before.
about the coaching calls?
Let me pause before we get to the coaching calls, because with those clients who have been with us for 10 or 20
Right.
years, some of the conversation then is not so much that you're going to leave mental health services and never come back. What would it take to get you to a point that you're comfortable trying this on your own for a while, and you are willing to go out there? And what would it look like to skip a few months of the services that we're doing? Well, I wouldn't feel comfortable with that unless I got engaged with, I know Momentum and some other places have peer support groups. We've got self-help centers in the county. I'd have to know where I'm getting my meds, and I'd have to be engaged with some of the other folks that I see around here who are, running groups too. Well, great. So when we can get you connected with those two pieces, then you're going to feel comfortable not having regular therapy sessions.
Yeah.
Is that what I'm hearing?
Right.
And then that can be the desired results.
Okay.
Yeah, we had actually done, as part of the redesign efforts, we had done a study at Momentum and asked the question to the clients. We essentially did the miracle question. What would life look like without us? And it freaked them out at first, but then what came out is, I need you because I need my doctor. That was the theme. We never, every single client said that. It had nothing to do with the case management, nothing to do with the therapy. It was all the doctor. So essentially, and they asked people who were in the system, I think that they were there for 10 years or more. And it was, okay, so the desired transition will be that they are connecting with someone on the outside to obtain their medication. And once they're settled with that, we know we can start transitioning. So running those kind of tests can also help. So real briefly before we move on, so you guys signed in on the outside forms with your address. That's going to go, Larry for the adults and Zelia for the FNC group will send you guys an email for the supervisors, managers, and leads on coaching calls where you will be on the phone with either Percy from CIMH for the FNC group or with Diane on the adult side. And what that is you're going to be going through, she's going to coach you guys how to coach, essentially, or Percy's going to do that for the other side. So something will be submitted in, it'll be an assessment, a narrative, and a treatment plan. Then the person who's representing that will give feedback on the feedback that they gave to their staff. And then Percy or Diane will give feedback on that feedback. And it's actually very beneficial because then you guys start getting those additional questions. You start going, oh, those are areas that we can kind of fill in the blanks. It's been extremely helpful for the pilot teams, and we've already done 2 calls for this set, so they'll go through June. So you'll be getting emails on that. So that's why it was really important for those that are supervisors, managers, and leads to make sure that you put your email addresses clearly on there with your name and your agency. Did you want to say anything else on that? Okay. So from desired transition, we're going to talk about strengths and resources. Again, there's that golden thread we're pulling through, the assessment, the narrative, and now the plan. These are functional strengths that apply to the desired results and to the goal that we're going to develop. So if we're working on something specifically like getting a job, and we put in that, let's see, what's something that wouldn't apply? That they like to sleep, because that could actually be a strength. That's not really going to be a strength to getting a job necessarily, you know? So you want the functional strengths that really apply to getting a job. For that, it could be that the person really likes to interact with others and finds happiness in being a peer mentor. That's a strength. So it's functional things. If they're resilient, what's that resilient piece towards? Because resilience is a big word. Looking for those pieces that really apply to the goal that you're working on. And these are things. Don't get into that habit of what are your strengths, because I will tell you the amount of people that I interview for jobs, if I ask what are your strengths, it's the So learning how to really pull those out and just say, I've seen you do these things and I really find that you're really great at them. Or asking the person, what are you really good at? What are your hobbies? What do you love to do? What do other people tell you that you're really good at? So exploring those other pieces, asking the family, what are these things? Because we've been so drowned in the deficit piece that the family can probably tell us, oh, well, they're not listening, or oh, they're doing this bad thing. What are they doing good? What are the things that we can build upon? And what's going to overcome the obstacles? So the obstacles, this is that core piece of our plan where before our goals used to be very we'll decrease anxiety from this, and that's where we would put all the symptoms and the behaviors, and while you can still do that in the goals, this is where we're probably going to hold most of them, because this supports the medical necessity aspect of a treatment plan as well, as it's tying to the goal. What obstacles, what symptoms, what barriers, what resources, what things do they lack in their life, what skills, what behaviors are blocking them from being able to achieve their desired results. Okay? So if they want to get a job, some barriers may be the poor hygiene. Because if you're going to go interview and you smell and your hair is kind of dirty, it may not go over well. Okay? So that's an example of something. But we also want to look at what's contributing to that. Well, perhaps there's some paranoia that around water and taking showers. So we want to incorporate that into this area as well. So it's strengthening the plan so that we're understanding what's going on in this person's life that's preventing them from getting there. And those strengths we talked about are functional strengths that are going to overcome these areas. You do not have to list all of the symptoms. You list the ones that apply to the goal at hand or to the desired results. So we may have a laundry list of symptoms the person experiences in the assessment, but we're pulling out the symptoms and barriers that are still linked to that diagnosis, but that apply to this particular desired result or goal. You want it to, I mean, you shouldn't be saying, like, if someone's got major depressive disorder, for example, with no psychotic features, and you're putting in that they've got paranoia, that obviously isn't linking, so you want to make sure stuff still links through. You don't have to point it directly to say depression symptoms, low energy, It's, yeah, you could just put in there, you know, this, you know, George experiences poor appetite, low energy, you know, and that's actually a good thing because the auditors in history actually don't like it when you just put depression, anxiety, because it's not specific to that individual. This is their plan, so really giving a clear picture of how those symptoms, what are they manifested in this person.
Yeah, and interestingly, what we've seen in terms of our own feedback as we've reviewed a lot of these and we've been giving some clinical supervision around the way plans were written, and even in engaging with the state and with our own local quality assurance initiatives, is it's very rare that somebody says you didn't have enough, you know, a long enough list of symptoms. We don't like this treatment plan because the list wasn't long enough. What we get is that we don't see the consistent thread from the assessment through the narrative summary into the treatment plan, that they all match up and they're in alignment.
Yeah.
So if you said depression in the assessment, you talk about the person being depressed in the narrative summary, and then you're listing off that the person is crying, they don't have as much energy, they're not eating and enjoying the things that they used to. That doesn't have to be incredibly long, but somebody's really going to see that connection.
Yeah, that connection has to be clear throughout. Yeah, and even beyond, we really want to get you guys beyond the auditing piece because it is incorporated. Medical necessity is well incorporated to this stuff. The piece that we want to look at is this is what is clinically appropriate for someone to get better. If they're seeing this long list of stuff, they're going to go, oh my God, this is impossible to do. So as long as we're keeping that thread throughout and keeping it consistent and giving that clear picture, even if it's just a few of those elements, that's going to be, you know, that's more meaningful to the client and still passes medical necessity aspect. So it's got both intertwined in it.
We're
She answered my
focusing
question.
as a system on this best practice in client service, and that's the focus. And everything within the system, including audit passing and all of that, is supporting this best practice. But this is where we're focusing instead of having compliance driving practice. We're
It's
focusing
best
on
practices, yeah. Yeah, because before it was this top-heavy compliance and best practice was down here. Now we're kind of flipping it where compliance is integrated in. We actually have a work group specifically working on a best practices manual so that integrates all the compliance pieces. There are a few members of that group in this room right now that are working specifically on that area, so that way it's really kind of reassuring everyone that this is okay.
Thank you.
Okay. So short-term goals. This goes right into the measurability question that we were talking about. This is like the really important piece. This is the part that if you want the auditors look at, this is where we're at right now. So we're looking at building on the strengths and resources. This is a functional goal. We're looking at skill acquisition. You can still incorporate symptomology in their behaviors, but we're really challenging you guys to look at a different perspective, something that's an outcome. So the goal is no longer necessarily, you know, reduce auditory hallucinations from 10 to 8. That people that know me know that I absolutely hate that one because I go, how the hell are you going to measure that? Are you crawling into their brain doing that? Like, how do you do that? This is flipping it into something like, okay, they've got these voices. What is it impairing them to do? Well, it's preventing them from going outside of their house or from making friends. So now we're going to create a goal because we want them to be able to function with these voices because they may not go away in reality, but that they're going to be able to do something in their life that's being overcome. Specific, observable, measurable. That's not going away. That statement is staying in here. So we still want to be able to see, how do we know this has been obtained? We also want to look at beyond the person, but incorporating that cultural aspect. So remember how we were talking about sometimes we're over here and they're over there, and finding that middle ground of recovery? Same thing there. If their cultural norms are way far away from what we're expecting of them, finding that area of how to bridge those two areas. This is also the stepping stones. So now we're looking at more manageable goals. So no longer are we having 6-month or 1-year goals. These are 2 weeks, 30 days, 3 months, maybe as far as 4 or 5 months, but you're starting to kind of bridge out. So short-term goals is the emphasis here. And you can have 2, max 3. I wouldn't go beyond that at one given time that you're working on, because now you're really kind of, how are you going to work on all of that stuff? I can see an FSP program maybe having more because they're seeing someone more often, as opposed to maybe a traditional program that's seeing someone maybe once a month. But you could work with 2 to 3 goals max. So short-term goal. How many people have heard of SMART goals? Okay, that's what we're looking at. We're looking at specific, measurable, attainable, realistic, and time frame. So by specific, we're talking about, rather than this large goal of get a job in the next 6 months, it's what are the steps to get that job? Well, the person is going to wake up at 8 o'clock every day, and they're going to take a shower at least every other day. It's measurable, it's observable, we see the change, and it's a behavior that they weren't doing before. That doesn't mean that they're going to be doing it tomorrow, but that's where we want to get in 3 months maybe, because maybe that's going to fit the person's lifestyle at that time. Okay? We're looking at behavioral things and understanding the person and keeping as strength-based as we can. So rather than looking at the deficit, what is the thing that they are improving in their life? What is the strength that we're building upon that we know that they can do? And for a long time, everyone always used to ask me, can we use those canned goals, you know, the ones that have already a formula to them? Can't we just use those ones? Okay, we're giving you something that's going to help you with things, but it still allows the uniqueness of the client to come out. Every goal should have all of these pieces incorporated into them. Okay, and this helps you stick with the measurability. Even though we were measuring things before, I still see people kind of leaving those aspects out. So this framework actually kind of keeps you to that. The individual is going to do something specific that we can tell is going on. We can see that change happening. For how long? When is it going to be done by? That's a real big key thing. That's the 30 days, 2 weeks, 4 months, whatever it is. And how will it be measured? And I challenge you guys to explore beyond by self-report. It's okay to put by self-report, but it starts to become this can of what is self-report. So I've actually started in my team meetings, I have a list, and every team meeting someone has to come and bring me a new other version of per self-report. No, partnership. The whole thing is in partnership. We've got, so you remember the interim form that we used to use that sometimes we'd use to add like an intervention or something? There's now an interim form, so you could say, okay, maybe it's 2 months in and we're not seeing much progress on the goal, but the desired results and everything are staying the same. You can do an interim update and do a new goal to kind of put in there. And add in whatever has to be changed. Maybe it was too big of a goal and you need to change it to make it smaller, or maybe they achieved the goal and we need to do a new one. So you're not locked by, at 3 months we must change this. It's, let's evaluate along the way and see where we are with this. And maybe those things, those natural things in life that occur that makes us revisit and say, you know, we're really working on this area, kind of like the example I gave earlier where it was like originally talking about work, getting employment, but really we're working a lot on housing, so maybe we need to revisit this. That's an option. And in the curriculum that you guys have, I believe we have a blank that has the interim up there, and I think the directive, yeah, the directive has it in it as well. Does that answer your question?
We have a Word version on the webpage that you can download and use.
Yeah. So it gives you kind of some tools to update. So you're not, that's that living document aspect that I talked about, where we shouldn't be just living by this date. The best practice is we do what's best for the client at that time. So if they're not ready for that goal, we reevaluate it. Or if we're finished with it early, we reevaluate and do something else.